Hello, my name is Jonathan Milner, and today I will be presenting on the ethics of machine learning in healthcare, informing decision-making in Alberta. This is my Data Science 690 capstone presentation recorded during the summer to 2023 semester. I chose this topic as it's related to my work as a senior analyst at Alberta Health Services. In my role, I provide decision makers with the tools that they need to make data-informed decisions regarding the caring of seniors in my local area. There are many potential uses of machine learning in healthcare. It can be used for monitoring patients for falls or irregular behavior. It could be used for predicting emergency room visits. It can be used to help manage staff schedules. It could be used to recognize diseases in x-rays or other data, and many, many more uses. While the ethical concerns regarding all cases are quite similar, I'm going to focus mainly on machine learning in predicting patient outcomes and determining interventions that might reduce risk. Jurisdiction here is a very important consideration. Healthcare is administered in different ways in different parts of the world, each with unique challenges. Additionally, existing laws and regulations vary by area. While the principles I discuss can be applied in any jurisdiction, my presentation is going to focus mainly on machine learning in healthcare in Alberta. To give a bit of an outline of the presentation I'm going through, first I'm going to discuss the main laws regarding, the use of health data and a government initiative on responsible use of artificial intelligence. I'm then going to review key principles of existing regulations and current approaches used to minimize risk. Then I will discuss additional important considerations for machine learning and provide recommendations for future directions. There are both provincial and federal laws regulating the use of health data. At the federal law, the main law protecting privacy is called the Personal Information of Protection and Electronic Documents Act, or the PADA for short. This law applies when data from multiple provinces is being used, or if the province where the data is being used does not have similar legislation at the provincial level. For research purposes, there's another regulation called the Tri-Council Policy Statement, Ethical Conduct for Research Involving Humans, or also known as TCPS2 for short. It provides the framework that research ethics boards across the country use when granting ethical approval for studies at universities and colleges. As Alberta has its own law governing the use of health data, the Health Information Act, this is the main law governing the use of health data throughout the province. The Act focuses on balancing the protection of privacy on one hand with the appropriate sharing of health data on the other hand. Neither PADA, TCPS2, or the Health Information Act talk specifically about AI and machine learning. This is a little bit of a deficit. To kind of fill this a little bit, the Government of Canada has been working on a project called Responsible Use of Artificial Intelligence. However, scope of this work is limited to governing the use of AI by Government of Canada departments. It doesn't apply to provincial departments or governments. It doesn't apply to health services, other holders of health data, just the Government of Canada. The project resulted in the creation of a directive on automated decision-making that federal governments must follow. The directive is based on 5 guiding principles, which I will quote. First, understand and measure the impact of using AI. 2, be transparent about how and when we are using AI. 3, provide meaningful explanations about AI decision-making. 4, be as open as we can by sharing source code, training data, and other relevant information. And 5, providing sufficient training. So a key component of the directive, a tool was created called Algorithmic Impact Assessment. This is a questionnaire that identifies the risk and impact of an AI tool used for decision-making. All projects using AI in federal departments are required to complete this tool, and the results are publicly available on the Open Government portal. Next, I'm going to go over some of the common important principles that are across the different privacy regulations in Alberta and that are particularly relevant in machine learning. So the first principle I'm going to go over is informed consent. When real-life health data is collected, its primary use is to assist the doctor in making decisions for your care. Uses for research, quality improvement, or population health are referred to as secondary use. Health Information Act, PAPEDA, TCPS2, all have components regarding individuals' rights to know how their data is used and kind consent if so desired. With the emergence of the electronic health records, it's possible to produce real-world evidence on a scale that was not possible before. For example, Alberta Health Services, the public health system responsible for delivering healthcare to all the 4.4 million Albertans, is in a multi-year process of combining over 1,000 different electronic systems and paper systems into one integrated clinical information system. The data collected in any healthcare interaction could potentially be used by, who knows, thousands of projects to improve healthcare now and in the future. So you can kind of see that it's not really feasible for an individual to provide informed consent for that myriad of potential secondary uses. So those secondary uses, not what like they went to the doctor for, right? To give the doctor the data to help them with their healthcare, but this is for research, quality improvement, and other projects, right? So it's not really feasible to get that informed consent for all those possible uses. Existing regulations allow room for secondary uses of data, such as machine learning, that could benefit the public without the express consent of the individual, while still ensuring checks and balances to avoid inappropriate use. For example, the TCPS2 says that health data can be used without informed consent only if the Research Ethics Board is convinced that it's not feasible to get informed consent, not just inconvenient. All right, so informed consent, one challenge that need to look for carefully when we're doing AI projects in Alberta and healthcare. Second principle is protecting privacy. Health data is very sensitive and must be protected. In 2021, there's a data breach affecting 360,000 different people in Ontario's vaccine management system. Same year, there's another breach of 200,000 different health files containing various information in Newfoundland. It is important that custodians of health data have the proper safeguards in place, continuously work to strengthen data security. The last principle I want to discuss is the importance of appropriate information sharing. While protecting privacy is important, it's also beneficial for the public good for it to be shared appropriately. Health data is collected and held by various organizations, each organization having different pieces of the puzzle. Well, it must be shared to facilitate machine learning and other analytics to be able to get that bigger perspective. Data often needs to be shared between clinics, for example, in primary care networks, Alberta Health Services, Alberta Health, which is the government department, research groups at post-secondary institutions, nonprofits, and private companies might even be involved to provide cloud or machine learning services, for example. While this sharing of data has benefits of increased knowledge, it also increases risk that must be minimized. So now that we've gone over some of the principles in it, there are strategies that are in place to help minimize this risk. I'm going to go over an example of how data is collected at a family doctor clinic and some of the safeguards from the Health Information Act that are in place to protect that data. First, clinics are required to have a visible sign in the waiting room regarding the collection of the health information. Each holder of health information, or it's called data custodian, is required to have completed a privacy impact assessment that details risks and safeguards that are in place. Some safeguards typically include things such as annual privacy training for staff, tracking access to data, performing audits to review potential breaches, and ensuring all those rules and things are in place. For example, it's appropriate for a nurse to view records of the patients they're seeing that day, but it is not appropriate for a nurse to view records of their family member or other people. And then third, the clinic can only share data with other custodians or organizations who have a data or information sharing agreement. And this sharing is very limited. It's typically limited to custodians such as Alberta Health Services, Government Department, Alberta Health, nonprofits such as the Canadian Institute for Health Information, who provide statistics and analytics for the for the health system across the country, and the Health Quality Council of Alberta, who provide some information about the status of healthcare in the province. Additionally, research teams at post-secondary institutions can make requests for de-identified data if they have Research Ethics Board approval. Oftentimes, this is facilitated through an embedded analyst at Alberta Health Services. That way, it avoids that risk of sharing raw data, and that analyst can just provide the aggregated data to them. There are other guidelines, and these and other guidelines are important to protect health information, allow the use of health information for quality improvement and innovation, while avoiding the use of health information for ulterior motives. Machine learning in healthcare has all the risks that we've discussed so far. Some additional risks include biased training data, black box decision making, and high stakes for accuracy. Looking at the first one, it's biased training data. As the saying goes, garbage in, garbage out. Machine learning predictions are only as good as the training data. If the training data is biased, the prediction will also be biased. For example, in hospitals, blood oxygen levels are routinely measured through pulse oximeters, little devices that clip onto the patient's finger. The initial studies were used to validate and calibrate the use of these devices consisted mainly of white patients. New research has found that Black patients had low blood oxygen when the device said that it was normal 17% of the time, compared to 6% of the time for white patients. So the accuracy is 3 times worse for Black patients as it is for white patients. This could have been avoided by collecting ethnicity data and comparing how the algorithm performs for different groups and modifying as necessary. Second, black box decision making. Many people are concerned about decisions made by an algorithm without being able to understand how the decision was made. People are much more likely to trust a machine learning algorithm if they have a sense of how the algorithm works. Years ago, home care needs evaluations in most North American and other places around the world were changed from a subjective approach to using an algorithmic tool called the RAI. This led to complaints for some patients seeing their approved home care hours reduced without explanation and no process to appeal the decision. There was a news article in The Guardian and The Verge with more information about this. This demonstrates how important it is to have ways to explain what factors are most influencing a model's outcome. One solution is to use easily interpretable models such as decision trees. However, this can be problematic as it could underfit the data, leading to inaccurate predictions. Using tools to show decision boundaries or relative impact of individual variables for making the prediction for the individual allows greater transparency while still allowing more complex models. For example, SHAP values have been used to show feature importance in a recent machine learning study on readmission risk of frail patients. Accuracy. Third, lastly, accuracy is very important in healthcare. For example, let's say algorithm that we're working with is used to predict the patient's risk of death following a certain surgical procedure. If this risk is not correct, it could result in false hopes or false despair, and vastly different decision makings by patients, their families, and the healthcare providers. While this risk is not exclusive to machine learning and exists in all methods of predicting risk, other methods, it illustrates that how important accuracy may be in healthcare settings. To overcome this, it is important to continuously strive to improve the algorithm's performance. Some methods of improving performance are including personal factors and methods such as recurrent artificial neural networks that can account for the patient's medical history, not just in the current state, but how they progress through time. Additionally, for high impact decisions, machine learning predictions should be used as a tool to assist in decision making, with the human still being the ultimate decision maker. Again, that kind of combines all these points, the previous point together, along with this, that the algorithm should have a way of seeing which factors are the most important for predicting that outcome so that the human can make that informed judgment on their experience and their human experience as well. In conclusion, I would like to make a few recommendations of ways to encourage ethical use of AI and machine learning to benefit healthcare systems, to benefit healthcare decision making in Alberta. First, build on the responsible use of AI project by the Government of Canada. Thought that was a great project and a lot of work was done on that. It could be applied to uses outside of the government. For example, health custodians could use the directive on automated decision making as a starting point for creating their own policies and guidelines. Additionally, this could be used as a starting point for incorporating into existing regulations such as the Health Information Act, PIPEDA, and TCPS2. Having guidelines in the law could make ethical use mandatory, prevent bad actors, and provide the ability to prosecute if willfully not followed. Second recommendation is very much with the first one, is that any policy should include that all AI in healthcare should require an ethical review, including evaluating the model for bias and not just accuracy. This could be done using factors such as model cards and other strategies. Third, data security is and always will be a concern. It is important to have experts in the area working to avoid any data breaches. Fourth, models that can be understood and trusted. It is important that clinicians and patients can understand what factors are most strongly impacting a prediction and be able to challenge the prediction if necessary. Fifth, like all technology, the use of AI has many risks, but also many benefits. Using AI for good has the potential to help alleviate some of the stress that the health system is facing and improve the patient care for Alberta. So while there's many risks and things that we need to be cognizant of when we're using AI, I believe that it is a very strong and powerful tool that we should continue to explore. And lastly, in the process, there's going to be mistakes. Models will always need to be tweaked, and we need to learn from the failures as a lesson to learn for the future. It's important to regularly evaluate models from both ethical and performance perspectives and work to make improvements as necessary and possible. Thank you for taking the time to listen to my presentation. I hope that you found it interesting and informative. I look forward to hearing your thoughts and feedback on the topic in the comments.